Well done for remembering, Fran.
I thought I should do it now, otherwise I'll end up forgetting.
I think we've still got quite a few people coming in, so we'll just give it until 2 minutes past. So if you want to go and make a very quick cup of tea, we'll start at 2 minutes past. Fran, do you want to change the slides from presenter mode just to full screen? I don't know if you can, maybe.
Let's have a look. Whereabouts is it? Where's it located?
At the top, there's display settings. That might be it.
Is that better?
Yeah, that's perfect.
Okay,
Thank you. Thanks for Katie Gillies for the little email nudge to tell me that they were in presenter mode. I hadn't realised. Okay, so it's now 2 minutes past, so we'll start. Thank you everyone for coming. First of all, welcome to this webinar, which is our sort of official launch of the INCLUDE Socioeconomic Disadvantage Framework. There'll be 3 speakers today, so I'm going to start us off. I'm Dr. Heidi Gardner and I work at the University of Aberdeen's Health Services Research Unit. And I've been working on this project with Fran Sherratt, who's based at the University of Liverpool, and Katie Biggs, who is at the University of Sheffield. And you'll hear from both of them later on, as well as discussing how we've involved patients and the public in this project as well. So Fran's manning the slides at the moment, so I'm going to do a Chris Whitty all the way through and do a next slide, please. So we'll kick off. Just to say as well, if you have any questions, we do have quite a bulk of time at the end, or we've planned for quite a bulk of time at the end. So if you want to put questions in the webinar chat facility, and we'll go through them at the end of the session so that we'll sort of power through the presentation, and then we'll do questions at the end. Everything is being recorded, so if you are part of the question session and you want to have your face shown or not, just be aware of that we are recording, and we'll be putting it on the TrialForge website at the end as well, so that we can, if you want to watch it back, it's there for you. Okay, so I'll start off. Who is underserved by health research? And this is a question that's been sort of floating around the area of trials for a long time. I think the last couple of years, particularly, it's been sort of something that has come up multiple times. And in the past, the language has been slightly troubling, I guess. So in the past, we've sort of referred to groups that are underserved by health research as being hard to reach or underrepresented. And the INCLUDE project that was run by NIHR was launched in 2017. Did some work with stakeholders, lots of public members and members of the public and patients that were involved in that project. They sort of settled on this term underserved as a way that it presents a different sort of facet of underserved populations. So instead of saying hard to reach or underrepresented, which puts the blame on those populations, we remove that blame and sort of put it on, I guess, us as researchers, I guess, and say underserved instead. So who are underserved by health research? And the NIHR INCLUDE project came up with sort of 4 broad areas that then had sort of more specific areas within there. So demographic factors could be a reason why people are underserved, and that would include age, sex and gender, ethnicity, sexual orientation, education status, and lots of other barriers and things within there as well. Disease-specific factors, such as if you have a rare disease or some sort of genetic subtype of a disease, if you have metastatic cancer, for example, health status, so if you're mentally ill, if you have experience of mental ill health, if you're pregnant, if you have a disability, whether that is physical or mental, or if you have comorbidities and sort of multiple issues or health issues that you're dealing with at the same time. And then social and economic factors, which are something that we think is tricky to deal with. And I think I'll go into a little bit later on as to why we tackled this part for this project. So next slide, please, Fran. So groups by social and economic factors, and you can see that when I mentioned earlier on that the INCLUDE project sort of has these subcategories, it's not a small list, it's quite substantial. So people in full-time employment, which you might not think immediately are a group that are underserved, but they are. And the group that we sort of tagged onto for this project and really tried to broaden out this category, so socioeconomically disadvantaged, unemployed or low income people. We sort of took a bit of a broader view, and I'll go into how we operationalize that in a little bit, but it's not just low income or being unemployed, it is this idea of being disadvantaged by your socioeconomic status that we are going to look at in this project. And the rest of the groups here do sort of, they come into this project, but they weren't necessarily the main focus for us. So people in alternative residential circumstances will come up for us. People living in remote areas may come up, but there's another set of work that needs to go on, in my perspective anyway, for people that live rurally and remote. Carers, language barriers, digital exclusion and disadvantage definitely comes up throughout this project. But what we're trying to say here is essentially that anyone who has a socioeconomically disadvantaged life experience is what we're interested in here. These are the groups that we want to make sure that we're trying to design trials that do not underserve them anymore. Next slide, please, Fran. So why do we need to think about socioeconomics? And this quote was something that sort of really hit me when I was doing some reading around this idea of socioeconomic disadvantage. But the material conditions in which people grow up and live have a lasting impact on their personal and social identities. And this influences both the way they think and feel about their social environment and key aspects of their social behaviour. And as I'm sure you know, if you've heard Katie Gillies in particular speak, I've already mentioned her earlier on, but trials are a behaviour. They are asking questions of people and asking them to change their behaviour. So instead of going to the cinema or taking your kids to the football, cooking dinner, cleaning your house, doing laundry, the millions of things that we all have in our lives, we're asking people to do something different. So that behaviour is impacted by people's experiences, their identities and the experiences that they've had in their life so far. So socioeconomics for us was something that we really wanted to tap into, because we feel that it's a big group that trials have the potential to have a big impact on if done right. So I'll tell you who we are in the next slide. Thanks, Fran. So you've already heard from me, and I will not ramble on too much longer because we do have other speakers. But so as I said, this will be Dr. Fran Sherratt, Katie Biggs, and then we had a team of 6 patients and members of the public that were sort of co-developers and co-designers within this project. And we very rarely met without them, to be honest. And they were wonderful, as I'm sure that some of them are on the call today, and I know that I've had chats with them since the project has sort of finished unofficially, I guess. But they really were a core part of our project team, and we could not have done this project without them. So when I keep referring to the project is a framework to guide the design and development really of clinical trials with inclusion of people experiencing socioeconomic disadvantage in mind. And that's tricky. It's something that we knew was going to be difficult, and we knew that it wasn't going to be a straightforward thing, and we would be relying quite heavily on the patients and members of the public within our PPI groups that could share their experiences and really sort of pull us up on things. Maybe it was the language that we were using that wasn't particularly inclusive at times, or even just ideas that we had that we then had to sort of unravel in our own minds, and new ideas that were coming in that we hadn't even thought of. And we really had the support, I guess, of the Trials Methodology Research Partnership. So this project was born out of the TMRP Trial Conduct Working Group, which is the sort of overarching working group of the TMRP. We have an inclusivity subgroup in there, which Fran and I are both co-leads of, which is open to everyone. And it's a subgroup where we work quite heavily, well, in a collaborative way, but also in a way that we want to include as many members of the public, patients, in the work that we do to try and make trials more inclusive. Next slide, please, Fran. So what we knew going in, I've sort of alluded to this, we knew it was going to be a bit tricky, but it really was this sort of, we were the polar bear at this point, and there was this big iceberg in front of us, in that we went in and we knew that socioeconomic status is not a protected characteristic, so it's quite a difficult concept and identity to sort of hold on to, if that makes sense. We knew that it was dynamic and that events and experiences can change quickly. You can be socioeconomically disadvantaged one day and not the next, and vice versa. It's not something that you can see, and we were very clear in our own sort of group when we were developing the project that this is not something that we wanted to necessarily identify, because that feels quite uncomfortable to us. We don't want to be picking out people and saying you're probably disadvantaged, because that is never going to work. It's never going to make things easier for people. And the language and terminology is likely to be quite delicate and require sensitivity. And for us, that was something that we were really conscious of, and that we leaned quite heavily on our PPI group throughout, because we knew that they basically, if they said that we were saying something that was okay, we could sort of feel a bit better within ourselves. Obviously, the group couldn't represent everyone, but it was something that we just really wanted to try and make sure that we made an effort with. We can't say that we've got it completely right the whole way through, but it's something that we've really tried to do. And again, we are really open to sort of feedback and ways to improve if people have comments on that. Next slide, please. So I mentioned that definition. Well, I mentioned this sort of why we need to talk about why we need to think about socioeconomics earlier on, but before we even started the project as a whole, we needed to think of some sort of definition as to how we could grapple with socioeconomic disadvantage, how we could get a hold of it in order to understand really what we were trying to do. So the definition that we came up with, and we did have lots of conversations with our PPI group about this, and really we did lean on them throughout this entire process. So socioeconomic disadvantage is more than low income, which is why we sort of broadened out from this NIHR INCLUDE project category that was in the list earlier on. It's the combined outcome of various situations and experiences that can change over time. And this was really key. The dynamism, the changing nature of things really came through in the conversations that we were having. And it describes the impact of a complex, multidimensional problem that encompasses the social injustices and inequalities that contribute to further inequalities for people in our society that are already at their most vulnerable. So how on earth do we operationalize that? How on earth do we give trialists the tools to nudge themselves in order to think about socioeconomic disadvantage when it's so big? It can change. It's sort of, it's in my head anyway, it's a little bit like Flubber, if you've seen that movie from the 90s, where it just slips through your fingers and sort of you can't really get a hold of it. So we're doing our best to get a hold of it here. And next slide, please, Fran. So in order to operationalize that definition, we weren't looking essentially for ways that others were operationalizing that definition to figure out how we could possibly split it, pin it down essentially, so make it less flubbery, I guess. So we came across the UK government's child poverty strategy, which was put in place between 2014 and 2017. And this was the one thing that I sort of came across and thought that makes sense to me. That is something that you can very clearly think of 3 different things and the various concepts that come within those. So that strategy had split socioeconomic disadvantage into 3 factors. So pockets, prospects, and places. And I'll go through those just a little bit as well. So pockets were income and resource availability. So literally, how deep are your pockets? And what is in your pocket, I guess. So an example would be being unable to work, insecure employment, and these I put in some quotes into this from our PPI group. So feeling powerless or vulnerable due to reduced income or resource availability. So it's not just about having, not having much access to money, not having the resources to do things. Maybe it's data on your phone, maybe it's heating. It's about the feeling that comes with that. It's feeling powerless because you don't have the ability to just go out and use a resource that lots of other people in society may have. Prospects, which is expectations and life chances, and that would come into low educational attainment, reduced literacy levels, particularly around health. And one thing that really hit us with the PPI group was the way that they said it was an acceptance of how it is. This is just their life now, that they may be unable to get out, or they feel that they may be unable to get out of this situation. And we know that things are dynamic, but unfortunately things tend to be dynamic in one direction rather than the other. So it could be that you're okay one day and then you're not necessarily okay the next. And it's very difficult to get out of that cycle of trying to get back into a place where you feel secure and you have positive expectations and positive life chances ahead of you. The next one would be places, so housing and the local environment. And this came into, this was sort of another area where we broadened out a little bit from that NIHR INCLUDE list. So reduced access to community services, lower engagement with the NHS, homelessness, travelling communities. So these 3 areas are the sort of pieces of the puzzle that we managed to wrangle socioeconomic disadvantage into pockets, prospects, and places. So they're the 3 things that we're sort of thinking about as we're going through this framework process. Next slide, please, Fran. And we wanted to build on what's come before. So if you've heard probably any of us speak before, and you've sort of aware of any of the work that we've done, there is already an INCLUDE Ethnicity Framework that was launched in October 2020. And that was directly as a result of the INCLUDE NIHR project. And with that ethnicity framework, there was already a development process to create these frameworks. And what we really wanted to do was build onto that and essentially not use anything that, not do anything that didn't need to be done. So the ethnicity framework used 4 key questions and then a set of worksheets to support them. So that's what we did as well. But what we then didn't need to do was to do certain things as part of their process. So this first sort of orange cross that's been crossed out here was the outline. So we already know that the way that the outline process was done for the ethnicity framework, for the outline for our framework, it's going to change hugely from that point anyway. So what we wanted to do essentially was just to go straight in with an initial draft, because we knew what the framework of the ethnicity project looked like. Go in straight in with an initial draft of the socioeconomic status, socioeconomic disadvantage framework, and then hit the ground running with it. So we didn't have to have this initial outline stage. We went straight in with the draft. We kept that stakeholder meeting, which was really, really important because we knew that we didn't know everything. We wanted a stakeholder meeting with a wider group of people. So not just us, not just our PPI group, but lots of other people within those conversations as well. So we had Talia Isaacs, who's a linguist. We had Teresa Cruz, a sociologist. We had lots of different people within that project talking to us and giving their perspectives on socioeconomic disadvantage and how we had moulded this initial draft. We then went away with furious notes and recordings of the conversations and modified that draft. And then we went straight back again to stakeholder feedback. So this was something that we knew that we needed to do, and we went back and forward with a couple of people who had particular points that we really wanted to get right. So we would modify, send it back to them, modify again, send it back to them until we had the vast majority of people on board with what we were doing and what the reasons behind those decisions were as well. And Applying the framework here is an area that we didn't do, and that was essentially due to funding constraints. So this project has been, we had the PPI group funded by the University of Liverpool Returners Fund that Fran had managed to access. But we didn't have any funding for this in terms of our own research time. So we just didn't have the time to apply the framework and give examples. But we are going to talk through some examples later on. Katie's going to talk through some areas where we can apply the framework and what we wanted to get out of it. And then the packaging. So that was nice and easy for us. We sent it to the web development team that work with the TrialForge project, and then they managed to package it and make it look similar to the ethnicity one, which we'd already sort of gone through this sort of user testing, stakeholder feedback area. So that's how the project has sort of come into development and what we've made. Fran is now going to talk you through barriers and strategies to make research more inclusive.
Thanks, Heidi. So the focus of these next few slides is on barriers and strategies to make research more inclusive, with a focus on socioeconomic disadvantage. But there is a lot of overlap here in terms of the barriers we identified with some of the other underserved groups as well. So first of all, I'll just talk to you about where these sort of pointers have come from. So it's an accumulation of work from 2 different projects, all of the patient and public involvement meetings that took part as a result of that, but also a couple of notes that were, annotated as well outside of those meetings too by public contributors. So in all, there were 10 public contributors that we've taken these notes from across 2 projects. So one of which the INCLUDE project, the Socioeconomic Disadvantage Framework project, which Heidi's just talked through that. And also a COACT study as well, which is a study that I'm leading, which focuses also on socioeconomic disadvantage, looking at how we can make trial communication better to improve patient representation in terms of those from socioeconomic disadvantaged groups. And there are about 3 note takers. So what I'll be talking through now, it's not a definitive list by any means. We're talking about the notes that we've amalgamated and hopefully some useful pointers in terms of strategies, things that we can put in place or at least consider, and the barriers that we need to be mindful of, I think, in terms of making sure that we're making our research inclusive of patients from socioeconomically disadvantaged groups. So a couple of points just before we get started, because all of this is relevant and some of which Heidi's already spoken about, but it's really important in terms of when we start thinking from a research perspective. As a researcher, if I'm designing a study, there are certain things I need to think about to make sure that this research is going to be inclusive, because ultimately, if we're not representing patients from socioeconomically disadvantaged groups as they should be in the population for which an intervention is intended, then it's unlikely it's going to work quite as effectively. There could be all kinds of issues. So it's really, really important if we want interventions to work in real world settings for our research to be diverse in this sense and representative. So with those issues that Heidi mentioned, socioeconomic disadvantage, it's complex, it's multidimensional. So even measures that we know are very commonly used to measure disadvantage, so for example, the index of multiple deprivation, it has something like 7 different domains, so things like crime, education, but you can score highly, where you live can score very highly in one domain and very low in another. So it is incredibly complex, I think, in terms of how we measure it, and also dynamic. So again, what Heidi was talking about in terms of you can go from being classed as, if you were looking to measure, for example, again, with something like the index of multiple deprivation, from being from, the lowest decile to the very highest decile and back again throughout your life course. That is going to change or can change. And then stigma as well. So this is something that came up a lot in the conversations with public contributors. So, socioeconomic disadvantage, it is stigmatized, but we need to try to think of that in a more positive frame and think about how it's actually an attribute, and it's a really valuable perspective that people can offer us, for example, with patient and public contribution. And as Heidi mentioned there, we don't want to categorize individuals as well, not to kind of try and move away from that, making judgments on people, which can be actually really harmful. And it, you know, the focus needs to be on making resources and the processes around trials simpler, show people that they're valued and that their contribution is important, and that will go a long way. And also just diversifying, like I think through the slides that I've got, I can't stress this enough, trying to ensure that we have diverse patient and public involvement in terms of socioeconomic disadvantage is really crucial to integrate throughout the research life cycle as well, to look at any specific issues that if a public contributor team is just going to be represented with people from the least socioeconomically disadvantaged backgrounds, it's not going to pick up on some of those really crucial points, I don't think. So I've grouped up, I tried to sort of theme these in terms of the themes that Heidi was talking about earlier around sort of pockets and prospects and place. So I'll talk about those that we've sort of themed up in terms of pockets first. So these are barriers and strategies that came out of the public contributor meetings that were linked with income and economic resource availability. And this is perhaps one of the most commonly addressed, I imagine, in terms of things like travel reimbursement is an obvious one that a lot of researchers often think about, but just that highlighting that taking part can leave people out of pocket, and what can we be doing to avoid that from happening, because it obviously will dissuade some people from taking part. So travel reimbursement is obviously is important, but if you can make travel, if it can be arranged in advance, if possible, then that will avoid anybody being out of pocket. But also something interesting that came up from the meetings was considering factors. So if, for example, you say, well, we'll organise public transport for somebody to get to a research appointment, but it's important also to consider factors that might impact the use of public transport. So, for example, if a patient was receiving chemo and their immune system's impacted, they're particularly vulnerable to infection. And, you know, thinking about the context of COVID as an example, they probably don't want to be traveling on public transport and put themselves at increased risk. So if there's certain things that might increase somebody's risk in that sense, then again, we need to look at what are the sort of things that could be put in place to support people still to participate in a study, but avoiding any increase in terms of the risk they experience. Childcare support was another one that came up quite a lot from the public contributors, and just trying to make sure that support is in place, basically financially, so that people can still participate even if they've got, you know, if they've got children. And avoiding research appointments outside of school hours as well. So again, you know, if childcare is obviously an issue outside of school hours too. So I think it's just about having conversations with people as well, and allowing some flexibility and ensuring that there is, you know, finance there to be able to support people to attend appointments. Moving on to sort of technology work and sort of government benefits as well. So again, the theme of income and economic resource. So there was a lot of talk about remote trials and digital trials, and that this is a good thing. It's, you know, we're trying to include people who might live a significant distance away, and that enables them. So there's a positive stance in that sense. But we also need to consider technological barriers. So do people have access to the internet? Do they have access to the sort of kit that you would need, whether it's a phone or computer, all that kind of stuff? So considering those sorts of potential barriers and other things that can be put in place to avoid that. So it might be about considering alternative formats, so people have the option of digital versus, you know, face-to-face, and financial support for technical barriers as well. So it might be, you know, for example, being able to provide people with mobile data so that they can access, if it's either a video call or if it's completing online questionnaires, things like that. Time off work as well. So again, this came up a few times. So just being flexible in terms of the appointments that we can offer people, if it's possible to do that, it will be massively beneficial and allow people to be included, because it's not easy for everybody in terms of trying to get time off work, and obviously there's a potential cost implication for that as well for a lot of people. So one suggestion that was put forward as well is producing trial teams producing a letter for patients to explain that they're taking part in the trial, and you know, some if they do have an appointment, that sort of thing, and then they can produce that for their employer. Being clear about research payments and the potential impacts on benefits. So, you know, obviously, if the sort of cash payments involved, then that might have an impact in terms of the benefits that people receive from government. So it might be about, firstly, it's just about being transparent. How might that impact people? But it's also about providing an alternative and saying, you know, we can offer this, or we can offer vouchers as an alternative if that is likely to be an issue as well. So moving on to sort of the focus in terms of well-being and life chances and the barriers around that. So first of all, it's just making sure that we can, you know, making things accessible and engaging in terms of the patient-facing materials that researchers produce. So there's obviously, like we were saying, there's a big overlap with a lot of underserved groups, and that links in very closely here, for example, in terms of language barriers or you know, certain disabilities. So making sure that these materials are accessible as possible, and also that consent is concise as much as it can be, different formats as well, and different modes, and producing patient materials in different languages as well. And one of the points that came up is, like, we know that, you know, information sheets need to be a certain length. There's certain things we need to, we don't all agree on this, but there's certain things that need to be included within information sheets. So if it's not a case that we can take something out, then it's about bringing forward some of the key points and highlighting certain things so that they stand out to people. And it just eases the sort of, you know, in terms of taking in those bits of information, bringing out the key points. Obviously avoiding acronyms and jargon. We all know to try to avoid doing that, but I've personally, I've noticed it does come up again and again in information sheets. It's not always something that's thought about. And making sure that they're visually appealing as well, not just a bulk of text, trying to break it down. So whether it's flow diagrams for a trial or images, just something that makes it more appetizing, and you know, in terms of actually taking that information in, looking at the flow of how a study works can be really useful, and using plain English, of course, as well. So the other thing that came up was sort of one of the points was being mindful of how information is sent as well. So as an example, there's obviously going to be many other examples than this, but one example was the use of sort of letter-headed paper in a brown envelope, and one contributor talked about how that sort of evokes negative associations, for example, with a debt agency, and so therefore it might be something to avoid. So it's those sorts of things that are really important, and that's one of the reasons why having a public contributor group that's you know, representative is really, really important. Something that's come up that's really stood out for me was just the power dynamics in research consultations between health professionals and patients, and how important that is, because you know, we're talking about, if we're linking socioeconomic disadvantage, people tend to be more vulnerable to sort of low self-esteem and low confidence and mental health conditions as well. So coming out of that, there are often sort of worries about being judged by people. Contributors talked about, you know, you might feel judged based on your intelligence or your education, and that just leaves people feeling out of place and uncomfortable in that environment, and untrusting as well, potentially, and powerless. So we need to be doing what we can to try and motivate patients to develop the trust and balance that power as well. I think this is a really important point that we often don't think about too. So yeah, some couple of ideas and things were to just be more transparent if we can, in terms of providing clear communication of patient and research benefits, because some people will come into it thinking, this is just for you and your study, and you just want me on board for, you know, so you can do this. How will it benefit me? Does it have any benefit to me? And so being very clear about what the patient benefits are and the research benefits, but also what the risks are as well. So we're sort of demystifying research and making sure we can build trust, which is really important, I think, in order to support people to continue with trials or participate. Another Another suggestion was regular updates as well. So thinking about how contributions help and informing people regularly in terms of where a study's up to, how their contribution has been valuable and has been beneficial. A couple of other points which I think were really important is ensuring there are fewer professionals perhaps in consultations, because this is part of this thing of it can be very intimidating for people. Allowing or supporting people to be accompanied by a significant other to an appointment if they don't feel empowered, that can help them and support them to feel that way. And potentially involving community champions as well was another suggestion that was put forward here too. In terms of barriers and strategies linked with housing and local environment, so some of these things overlap with those that I've already spoken about, but looking at, access to services and research, and also the stigma of place. In addition to financial expense that we've already spoken about, there's the idea of access to travel and childcare if you're living quite remote, or living in certain environments. It can be difficult to even access those things. So it's not even necessarily about the money. That could be a secondary issue. So thinking about that and looking at, is there anything that can be put in place in terms of that, is an important factor too. So things like choices for consultation environments, the mode in which it's delivered and the times, those sorts of things that we've already talked about a little bit. It's really important to consider those and what can we do to make it inclusive as possible. And widening approaches to advertising as well. So social media was spoken about in terms of potentially a negative thing, in that a lot of people, the only information that they might receive about research can be from social media, and we know that there's a lot of sort of fake news, conspiracy theories, things like that around research, especially linked to COVID and vaccines and things like that. But that could be the only source of information some people have. So it's that was talked about. But so how can we sort of I suppose combat that, but also how do we widen approaches to advertise research opportunities, and social media was spoken about there as well, and also linking in with local venues. Are there opportunities within local venues or local communities that we can advertise research opportunities, places that we might not ordinarily think of in terms of recruiting people, that might be a good opportunity to draw people in who might not ordinarily participate in research, or just in improving knowledge about research. Avoiding making assumptions about where someone lives as well. So again, Heidi touched on this earlier as well, but it is really important. We're talking about that last slide where, people are feeling stigmatized or feeling judged, going into an appointment and then being asked about where they live. It might be an innocent question, but potentially people can then feel more alienated as a result of that as well. So yeah, just being mindful of some of those things, I think, will help and go a long way to trying to make things more inclusive. But ultimately, like I say, this isn't a definitive list. It's not a one size fits all. Every study is different. There's going to be some of those issues that are more or less applicable. There's going to be things that aren't considered here. So again, having PPI and having as representative of the ultimate population you want to you want that your intervention or treatment to be accessed by, then it's really important to make sure you've got that, and that thread goes throughout your study as well. So I'll pass over now to Katie, who's going to talk to us about an example application of the framework.
Hi everyone, I am Katie Biggs. I work at Sheffield Clinical Trials Unit. Do you want to skip slide, please, Fran? I lead on the Access project, which is funded by the NIHR CTU efficiency funding, and the project aims to identify activities or strategies to improve representation of underserved groups and aspects around implementation of these strategies. The project has 4 stages: a scoping review, meetings with stakeholders to identify what activities are going on around the country at the moment, and a redesign of existing trials, and then interviews around implementation. The redesign part is relevant here as we use the frameworks for this stage. We redesigned 3 trials with a stakeholder group of trialists, other researchers, patients and clinicians. We looked at a drug trial in diabetes, a stroke rehabilitation trial set in care homes, and a cognitive behavioural therapy trial set in primary care, which is what I am going to talk about. For the trial of online CBT, I'll say, for computer, yeah, so I don't have to keep repeating myself. The Access team started with the Socioeconomic Disadvantage Framework. A research assistant and I worked through the worksheets in the framework. We used barriers and the potential solutions that arose during the roundtable meetings, the scoping review, and our experience of trials to draft the redesign, which was then discussed at the full 2-hour meeting with stakeholders. Next slide, please, Fran. So just a brief peek over the study description. It was the population was diagnosis of depression recruited by GPs. It was over 18, so adults. And they were screened with the PHQ-9, which is a measure of depression severity that's commonly used in research and healthcare. They were screened with that at entry. They included patients with some comorbid physical illnesses and non-psychotic disorders, but did exclude people with psychotic depression, people who are actively suicidal, people experiencing psychotic symptoms, people who are depressed in the postnatal period or have recently suffered bereavement. So quite a few people were excluded. They also excluded patients who had alcohol or drug abuse as a primary diagnosis, and people who were not able to read and write in English. The intervention was 2 online CBT interventions, so delivered via a computer. This is an existing trial that we redesigned. It was done quite a while ago, so they didn't really have apps then. It might be a bit different now, but these were delivered via the computer. And intervention delivery could happen at the patient's home. They could do it at the GP surgery, or they could choose a location, sort of a community location close to their home, to complete this sort of self-directed CBT. The comparator was usual care as delivered by their GP. And the outcome, again, was the PHQ-9, a very commonly used depression severity measure, and then other self-report measures, so all completed by the patients. During the first 6 months of the trial, participants were allowed to could complete questionnaires either face-to-face interviews or via telephone, according to what the patient preferred. But to improve follow-up rates, patients were later allowed to return questionnaires by post. It was an individually randomized controlled 3-arm controlled multi-center trial. And there was interviews with patients and health professionals that looked at sort of computer literacy and self-directed CBT, and then some cost effectiveness work. Next slide, please, Fran. So we're going straight into the worksheets. My slides are not as pretty as Fran and Heidi's. I'm sorry, they're just tables, but these are the tables straight for the worksheets. They are set out as shown here. I've tended to use 2 rows from each worksheet to go through on these slides. But for example, under health condition, on this sheet there are 3 questions and there's 4 under perspectives. Each worksheet's got between 2 and 7 questions, just over 32 in total, but it really helps to break down the elements of the trial. So that's what each question breaks that down to help you think about the design. So this is worksheet 1. Are people from different socioeconomic backgrounds likely to respond to the intervention in different ways? And this really highlights the barriers relating to how the health condition and how healthcare access might impact on the response to the intervention, and relates to question 2 in the framework. Stakeholders talked about how people experiencing socioeconomic disadvantage might disproportionately suffer from depression due to a number of circumstances, which Fran also mentioned. That socioeconomic disadvantage is linked to inequalities across the board, and people often have comorbidities, and that there is limited healthcare access for a lot of people experiencing socioeconomic disadvantage, and there are issues in defining and measuring socioeconomic disadvantage. So just as something to note, when you are looking at socioeconomic disadvantage, it's hard to tell the impact of it if we're not even measuring variables. So for perspectives, how it might, this case, we're talking about CBT, so the barriers here in relation to the online treatment, but also in relation to just accessing treatment for depression. It's quite important to note that there are fewer GPs in area of socioeconomic deprivation. There might be more chemists, but there seems to be less GPs. Next slide. So worksheet B goes through the barriers around how the intervention is delivered in the trial. Here I focused on what the intervention is. So here it's an online self-guided CBT and how it's delivered, which is through a website accessible for a computer. This was designed to be flexible and not driven by appointments, which has obviously been raised as an issue. And so the trial put some things into place to make it more accessible, but there are further considerations for online interventions. Again, Fran went through a few of these, the cost for data and devices, but also the fact that there might be low literacy and low digital literacy, and quite a lot of self-guided interventions might not have that the right level pitched to them. Again, not feeling educated enough to take part in sort of self-guided intervention, something Fran mentioned, the impact on how people might feel. And the other thing for self-directed, that people might not have the space at home to complete the intervention all the time, or the social support. And if they weren't going to complete this intervention at home, it was to be at a GP. So then considerations around transport and those costs. Next one, Fran. Worksheet C goes through the elements of trial design that might impact on participation, and this is broken down into 4 subsections. So this is C1, worksheet C1, which relates to trial eligibility and accessibility. And for this trial, I mentioned people needed to be diagnosed with depression and identified by their GP, though participants were also screened for depression with PHQ-9. So there was a question at whether you could include anybody as long as they were screened to have depression. They did include people with some comorbidities, but some exclusion criteria was questioned, for example, drug and alcohol use, postnatal depression by the stakeholders. And it wasn't always clear why those exclusions were there. So it would be helpful in knowing if they can be amended or removed to include more people. What was important to think about is if these groups of people might use the intervention, if it went into usual care, then they should be included in the evidence base. So it did say NICE guidance didn't recommend online therapy for depression and psychosis, so that they would not be expected to use it if it went out. At the redesign meeting, there was a lot of discussion around whether the trial should have been widened to invite people outside of GP lists, not formally diagnosed with depression. And this is really dependent on the research question. This trial was specifically set in primary care. That was the call. And so was focused on this. Where there is an interest in cost effective to the NHS, it is more likely to be focused on NHS services. So that's for sort of funders and researchers to think about the scope of their questions, and including people who may not access healthcare. So related to how people are invited to the trial when sending invitations through the post, as Fran said, important to think about potential connotations that might be associated with that. Throughout access and the development of this framework, there was a lot of discussion around literacy of information used in trials, of very long information sheets, again, something that Fran has mentioned. And then that recruiting through people and through personnel can also lead to issues around power dynamics, again, that's something that Fran mentioned. And some stakeholders that have clearly highlighted the difference even with how we address doctors and nurses, that nurses tend to give you their first names, doctors don't. And the differences in the level of language used, suggesting that academics and clinicians use more everyday language in their interactions. Next slide, please, Fran. So worksheet C2 breaks down elements of the data collection. Although the trial did allow the existing trial did allow telephone, post and face-to-face methods, I did think it was good to just highlight various barriers around data collection methods. And I think this shows that it's preferable to use a variety of methods where possible, as there may be different barriers for different people. So the telephone follow-up planned in this trial, so you have to consider sort of mobile and telephone access. I also put internet there now because there's also likelihood you would do an online meeting. So those things need to be considered. And then how, again, the people collecting the data might impact on how that data is collected and where the data is collected. So again, thinking about where it has to happen, but really thinking about remote data collection issues, because it's not necessarily a catch-all or a solution to visits. Next slide, please. So C3 breaks down what factors that might affect the analysis of the trial results. We would discussed issues affecting retention, things that have also come up before. So the time required for the trial and finding the intervention unacceptable once it started. And really how the impact of other things they've got going on in their life might stop them from carrying on. There's at one of our meetings, one stakeholder said there are a lot more things to worry about than research. So you're always going to be down the list with a research study, and that you need to consider that and respect that. And as mentioned before, issues around what data is collected, it's not always done and it's not consistent across trials, so it does make comparisons and analysis different. Subgroup analysis is not always possible if that data is not collected. And in relation to harms, there may be a difference in how the harms are reported by individuals experiencing socioeconomic disadvantage. Again, that sort of acceptance of how it is. They've got too much going on to sort of notice the harms that other people might notice. They haven't got might not have the social support around to point out that the things have changed for them. And so that's important to consider how that's reported and how objective or subjective that might be. Next slide, please, Fran. So this worksheet covers dissemination. It's again, stuff we've mentioned before, so relating to low literacy, but also around where the results are disseminated. Is it being shared in places that people have access to, rather than just in sort of university and healthcare settings and in academic papers. And then next slide, please. Yeah. So all of those worksheets then lead to this worksheet D, where you can list all the factors that might limit participation, propose measures that might help improve access for everybody. As you will have seen through the discussion of the worksheet, solutions do arise just through sort of discussing those things, and even just being made aware of the barrier can be helpful. Again, Fran's gone through several sort of general suggestions that can be considered across all trials. I've listed factors here, combined some of them. For example, literacy should be thought of across the board in all patient-facing documents with the appropriate PPI to develop and test those documents using layered information and videos in recruitment, intervention, delivery and dissemination. And to avoid reducing errors, to avoid making errors such as sending brown envelopes, you can also get PPI on sort of the methods and the modes of recruitment. Costs, I think, as Fran said, is probably the one that researchers think about the most, but really thinking about how providing anything up front where possible. Yeah, also completes time costs as well as funding. So you might want to focus on primary outcomes and have that flexibility in when it can be completed, and consider routine data to reduce the impact on patients. Power dynamics, again mentioned, we could be training our researchers, intervention delivery and data collection staff in these factors. And then as it was an online intervention, something being used a lot now, spurred on the pandemic, lack of access and improved technology. It's important to note the issues around digital access and the literacy level and health literacy level in self-guided interventions. People experiencing socioeconomic disadvantage may also have a lack of social support, and additional training, guidance, and perhaps videos and support from staff should be provided. Data collection around socioeconomic status is limited and inconsistent, rarely looked at in relation to dropout, but stakeholders thought that was really important, so we should collect data, though there is issues around what data to collect, and where possible include extra methods to find out where people are dropping out and if this differs by underserved group. There were interviews in this trial which explored digital literacy and self-management, but any qualitative work should also be representative and explore differences between underserved groups. That's it.
Thanks, Katie. So yeah, we've come to the end of our slides. I can see we've got a couple of questions. We just wanted to say a big thank you as well to all of the stakeholders who contributed to developing the INCLUDE Socioeconomic Disadvantage Framework, especially the public contributors who were intrinsic in terms of developing this framework, and also to the COAC study as well, the researcher on that, Mariana Popa, and the public contributors too, as their some of the findings came from in relation to barriers and strategies came from some of the PPI work there. I'm mindful, I think all three of us have probably spoken for more than we'd anticipated, but hopefully that shows how passionate we are about this project. So we have got you know, technically 5 minutes, but the three of us will be staying on beyond 12 o'clock for any other questions. If you have to go at 12 as well, that's no problem. If you've got a question, you can email one of us. The details are on the screen as well at the moment. So what we'll do is we'll sort of dive right into the questions, if that's okay. So we've got two up there at the moment. So one of the questions says, we offer payments to cover travel costs on a number of trials, but have real difficulties in implementing this. No mechanism for trust to reimburse for taxis or bus fare on the day, no petty cash. Trust struggling to book taxis even when there is an account with a local firm, as it is for research using hospital transport can be unreliable and have lengthy waits. It would be great to hear if others have been able to reimburse cover travel costs for patients. That sounds like there's been like a lot of challenges there. Me personally, whenever I've had to reimburse patients or pay them up front, it's always been through the university. So we've got, you know, things in place to be able to do that. But I don't know if Katie or Heidi, you have any experiences of that?
Yes, so sometimes we do it. I think payment through any big organisation is quite difficult. I do think it's a common thing that comes up. Unfortunately, fortunately for us, our main trust does seem to have a sort of research account for taxi booking, so we get them to do it most of the time. But I can see how that's an issue if your trust isn't doing that. But I think yeah, payments is always a problem.
Yeah, I would just when we're talking about reimbursement, I think it's really important to talk about paying up front as well, because reimbursement is great, but it can take time, and it also you're relying on people having money up front. I know that Sean's just put into the Q&A here. Sean Treweek, travel costs. Aberdeen is piloting something called ClinCard. Some great advantages, including immediate or pre-meeting payments to PPI contributors. And as far as I know, it's basically like a Visa card that you would use. And you can, as researchers, you can then sort of load it virtually for people to use before they get to the meeting or the appointments. I think something like that is where we should be going to try and make sure that we're not doing reimbursements after money has already been spent. I think it needs to be us pushing back on finance departments and the way that processes are happening and things like that, and trying to make sure that we can get money into the hands of people when they need it rather than after they've already used it. Personally, there are lots of frustrations, but I guess things that we've done in the past is like I've personally paid out of pocket and then claimed an expense back, which is not useful for a lot of people and is tricky. But I think if it's not a huge amount of money and you can afford to do that, then maybe that's a temporary workaround, but it's certainly not a long-term solution.
Okay, and I'll move on to Sean's question, or Sean's point now, who says that Katie has just mentioned information sheets and literacy challenges. Do you think your work supports a shift in how we deliver information to potential participants, regardless of socioeconomic disadvantage, with less emphasis on what is written in information sheets and more attention to given to what we tell people? I think for me personally, the work that I'm sort of leading at the moment has really focused on verbal trial communication, which I think is incredibly important. Often the interviews that I've done, there's a focus anyway where people say that what they've heard or what they've talked about has been how they've made their decision as opposed to what they've read. I think it is really, really important. I'd like to think there are, like Katie's example just demonstrated then, like noting and thinking about power dynamics isn't something we often do. Just think like travel reimbursement, that's going to help somebody get here. But those sorts of things like the power dynamics are really, really important, I think, and just how people feel. And that came across so much in the meetings that we had. So I think that there will be a shift, and I know there is work ongoing. That's something that has been identified through the COAC study that we're hoping to publish over the next couple of months, in terms of how health professionals speak to people from different backgrounds, even, and those differences that occur. So that will be building on a large piece of work as well, so we can produce some guidance. But I think the framework will be really useful because it's thinking about things like Katie's mentioned about training. So yeah, I go off on a bit on that. But yeah, Heidi and Katie, just wondered if you've got anything else you wanted to add.
I think something is really strong. I think working in trials, you're well aware how long all of our patient information sheets are. And just the feedback I've been having from loads of different sort of PPI stakeholders is that it's just not appropriate, and it's not, the language is not great. I mean, people don't even like the word trial. So I think as researchers we need to sort of do what we need to do for the legal, but I think focus on, like you said, talking and training people to really get the right information across. I think more needs to be done in this, because it's a big feedback point.
Yeah, it's definitely something that comes up time and time again. I think we're often pushing against what's always been done, templates of what we've always used and things like that. And I think it is a kind of, the minute that one study does it differently and we know that it can work and it can get through ethics, for example, we then all need to sort of piggyback onto that and say, look, this was done, send it to your ethics committee, make sure that they're aware that things can be done differently, because it's not just like the hurdles of the trial team, it's the hurdles of the approvals process that has always been in place the way that it is now. And yeah, I think we need to really focus on delivering information in a more creative and personal way. I think at the moment we're doing it in quite a template, formulaic way, and it definitely needs to change. I think socioeconomic disadvantage is part of that, but as you said in your question, it's any participant, and we are definitely losing participants because of the sheer volume of paperwork that we put in front of them, expect them to understand and take in and all the rest of it. So yeah, definitely I would hope that it is there's a shift coming, but I'm not sure how speedy that shift will be.
And the next question, this might be particularly suitable for you, Heidi, having worked on the ethnicity framework as well. Oh, hang on, I've just lost where I'm up to. What do you see as the role of research funders in implementing this framework, or expecting their award holders to use it?
Significant. So with the ethnicity framework, we did a lot of sort of banging the drum to lots of different people, and Sean Treweek, who the previous question was from, led that ethnicity framework, and we particularly worked on making sure that NIHR had buy-in right at the beginning. So when we said this was going to be an NIHR INCLUDE ethnicity framework, it was an NIHR INCLUDE ethnicity framework. It wasn't just us hoping that the NIHR would take it on. There was buy-in at the beginning, and that meant that it then went into their guidance for applicants, which I think is where most of the sort of understanding and knowledge of that ethnicity framework came from, in terms of, you know, people in the trial space that don't know us using it. It's also then gone into welcome guidance. It's gone into, you know, various funders, CSO guidance, that kind of thing, various funders around not just the UK, but there's a Belgian funder using it as well. And it is kind of, we're very aware that there's various frameworks now being developed, and there's a potential for, yeah, it to be overcome, trials to be overrun with work of all these frameworks to be completed. But we are working with a PhD student that I think is on the call, Azar, who is working on bringing all those frameworks together, so that it's a more sort of intersectional view on the frameworks and the characteristics that we're talking about. But for us, it's definitely the funders are the ones with the money. So, we do things in response to money because that's how the research world works, and that's how we can fund the projects that we're doing. So research funders have so far been very, very positive and helpful with the way that they've been doing things. But if you have other funders that you are working with and they could potentially benefit from this, let us know, and I'm more than happy to have those conversations to try and get it into more funded guidance, because that for us anyway. My perception is that it's the best place for impact to be made in terms of people using the framework.
Somebody's just mentioned, linking in with that point, an example of the British Heart Foundation cutting a lot of funding recently, and that things like patient travel are quite limited, and it's just difficult trying to account for those things. But I think you've sort of answered that, Heidi, in terms of it. I suppose it's like NIHR are hopefully going to be sort of like a trailblazer in terms of like this, making sure that we are doing things that are inclusive and accounting for those and expecting those sorts of additional costs to come up. So hopefully those others will sort of follow suit, and work's being done to try and address that as well.
Yeah, and building it into budgets as well. Like it's difficult to do things when your trial's already been funded and you already have a budget to work towards. But if you can, in future trials that you're working on, if you can build the framework into that to say, look, these are the reasons why we need all of this money for XYZ, then it makes the conversation much easier, because that funding is available in some way, because you've warned them in advance and said, look, we're probably going to need this, and it's in the budget that we've given you.
And Andy Meekins asked, one issue for working with people experiencing homelessness is reliable communications. I ran a support project that provided people with a cheap mobile phone and credit. This works for support workers to stay in touch. Perhaps it would help in the context of participating in clinical research too, if not already done. I think that sounds like a really good point as well, and in terms of potential, because it's often like an underserved group that we don't consider as well. So yeah, I think that sounds like a good point.
Yeah, and it's something that I think it's an underserved group that often it's straight away it's discounted, that they're discounted because it ends up being like, this is going to be too difficult, let's just focus on others, sort of thing. And that's why we're in the situation that we're in that so many of these groups are underserved. So we need to try and tackle these tricky things. Homelessness is a really difficult thing for a trial team to deal with, but I think even if you start working with support services and things in the community, because lots of them will see the same people day in, day out. There's lots of sort of soup kitchens and that type of model working in cities around me, I know, for example, and they see the same faces all the time, and when they don't see the same face, they recognize that person is not there. So even just trying to work with particular groups to try and maintain those communications, and something like a cheap mobile phone in the grand scheme of things is not going to add a huge amount to your budget, but could make a real difference to the outcomes of the trial at the end.
Fran, I think I clicked on Kim Thomas's question, so it's missed at the top. You mentioned involving community champions in research visits and wondered if you had any advice on how to do this. Did you mention that? Have you done that?
Yeah, so that came up a few times in terms of community champions or advocates. So looking at how, somebody as an advocate to bring forward. I think much of that will depend very much on the individual trial and, in terms of trying to identify someone. I think that's where PPI will come in really handy, because it's not something we expanded on an awful lot. But I think my impression was that potentially there might be people, whether it's other public contributors or whether it's certain venues that might have like a representative there to support people. That was my understanding of how you might go about doing that, or who you might involve.
I think doing that, having a community champion as well, is really helpful, and I've like sang the praises of Equality Health to multiple people, so lots of you will probably know them from just me ranting at you at how great they are. But Equality are a group that I've worked with multiple times on lots of different projects and will continue to do so. And they essentially, they're the bridge between the researcher and the potential participant or the community group or whoever you're working with, because in the research culture that we're in, everything is very project based. And so, you know, I'll work on a project and then I'll get, once that comes to an end, I'll then get a new contract and move to a different project. It's very difficult to try and keep those connections and relationships alive, because you're working on different things. And yeah, it might not be that you're working in the same sort of space with each contract that you get, particularly within academic research. And so with Equality, we go to them and say, look, these are the types of groups that we need to hear from. Can you help? And they then go and source, you know, find those people, set up meetings and make sure that there's a bridge then, so that even, you know, towards the end of the project, they'll get results of the project, and there's someone else to contact other than the researcher, who is usually on some sort of temporary or fixed term contract. So it means that the long-term relationships are grown and cultivated and nurtured. And I think doing that is really helpful, because it means that it's not a sort of mad panic of the researcher going, oh my God, how on earth can we find these people? And I've got no links because I've, you know, ditched the links from the last project because they're not quite relevant here, and all that kind of thing. So it's really, really helpful to use an outside person, essentially, that can be that nurturing bridge. But it also speeds things up because they already have those connections and relationships and things built, which means it's much easier to get those people on board and get information.
We've also got another point about how it's useful to know about sort of brown envelopes and connotations, and that being a point that's not being considered. And Anna Anderson asks, I was wondering if white envelopes are viewed as more appropriate, or if there's a preference for correspondence via non-postal routes. So I think with the contributor meetings that we had, I don't think a preference as such in that sense was brought up. It was just that was an example of, you know, how some sort of routes could have connotations to be avoided. I personally, I know I seem to just go back to like the PPI all the time, but I think that would be a question, again, unless there's some evidence in the literature, but I'm not aware of, and specifically around that. Then it's definitely a question that would be raised for patient public involvement, and to try and get some feedback there if you can get a group of people who are sort of representative in that sense. But yeah, I know there is a fair bit of literature, isn't there, in terms of how information is presented, but whether there's something on that in specific, I'm not sure. So Rebecca Barnes has asked, I take the point about not labelling people or stigmatising them, but please could you share your views on whether and how trials should collect data about socioeconomic status, given how multidimensional it is? I think, I don't know about you guys, but I think it's a really difficult one to answer, and anyone I ask seems to have a different answer to this question. There's obviously like common measures that can be used. So I mentioned earlier in the presentation on the index of multiple deprivation, where you'll speak to some people about that and they'll talk about how flawed it is in terms it will map a big area of geographical space, and then everyone's clustered within that. So obviously, you know, it's flawed in that sense, but it's probably one of the most commonly ones used for in England in terms of trying to associate people with a socioeconomic status. And also it's based on postcode alone. So it's not particularly invasive in terms of how many questions you ask people. But I think that's sometimes people have said whether, you know, people get free school dinners is a marker for sort of paediatric work. So yeah, there seems to be a lot of different answers to that question, I think. I don't know if you've got anything you wanted to add, Heidi and Katie.
Yeah, I think I live in Scotland, and postcodes are bigger here, or they cover more area here. And so I'm usually the person that's saying that the index of multiple deprivation is flawed, because particularly in Aberdeen, there's a road where most of the houses are £1 million, and the beginning of the postcode is exactly the same as the social housing, you know, 4 streets back. And so it's very difficult for me to try and get a hold of that and to make it useful. But I understand that we need to collect data on socioeconomic status in order to see whether we're improving. That's a really important thing, and we've done some work on ethnicity around data collection and things, but I think there probably needs to be a significant amount of work on this before it's done. Lots of times we go in and we're like, well, we need to collect data, and so we'll collect data, and it can be done in quite an insensitive way, and then you burn all the bridges that you've supposedly tried to make previously. So I think there probably needs to be quite a lot of qualitative work on this, with people from various socioeconomic statuses and various experiences, and saying, how do they want data to be collected? How would they feel comfortable to have their data collected? And if you ask them certain questions, would they answer? Would they feel comfortable answering? Because it's not a protected characteristic. It is something that is quite diffuse and dynamic and tricky, and people have the right to not answer those types of questions. And I think the initial sort of push to say, well, we're just trying to involve everyone, is probably a better way to do it, but we need to collect that data as well. So I think there probably needs to be significant research on this before anyone goes in and says, right, well, we're going to collect it this way, because as I said, I'm very nervous about the way that you could then burn bridges going in to say, well, I want to know whether you're on government benefits of any kind, and then people go, hang on, why do you need to know that? Who's going to have access to this information? And therefore they lose trust in trials completely, and health research more broadly. So not a very helpful answer, I'm aware, but I do think that there needs to be lots and lots of work done on this before we go in doing any damage by accident.
Katie Gillies has said that she's had to go, but she had a question about whether we've looked at effective interventions to improve recruitment of socioeconomically disadvantaged patients to activities such as cancer screening, and whether these interventions could also be used to improve recruitment to other health-related activities such as trials. So I can say first of all, I haven't looked into those sorts of interventions personally. I don't know if anyone else has.
No, and I've done a sort of scoping review, but where I've done for looking for activities to sort of improve recruitment of underserved groups, but I've always focused on trials, and there's very little.
Yeah, I think that is probably the next step of
looking
outward to see how other people are doing it, whether it's screening that's improving things. But we did have a grant in, I'm not sure what the outcome of that grant will be. I think it'll be February, to look at cancer screening in particular, and various types of disadvantage, and socioeconomic disadvantage will be part of that. So hopefully we'll get to do that work at some point, and we can then pull that information into trials. But I think overwhelmingly the health services are struggling with how to engage socioeconomic disadvantaged people in their services, and it's not just trials that are struggling, it's health research, health and lots of other things. So we definitely do need to look outwards, and I think even looking at things like survey response from market research companies and that kind of thing, how are they doing things, and how can we learn from that in a trial space? I think it's really important to bring in various disciplines in this, because we're just going to continue to struggle in our own discipline unless we try and learn from what's been done before us.
Carol Borges has asked, do you think we need to be pushing governance more to accept innovative, acceptable patient information sheets? We have recent experience of patients wanting information sheets in a certain format, REC discussions being supported, but governance being less supported. That sounds really interesting. It's not something I've come across personally, but if there is an issue, that'd be interesting. It sounds like it's a potential piece of work in itself in terms of figuring out what those sorts of issues are, what kind of governance issues have come up, and how to sort of overcome them. It sounds as if they could, like perhaps draw on some of the evidence base in terms of, or again, like drawing on PPI in terms of what people have wanted. It's I'm sure that's probably is what has been done perhaps as well in terms of the response, but that's a difficult one.
I'm always pro pushing back on authority. I just think there's the attitude of this is how we've always done it and this is how it's acceptable is so widespread that we need to be pushing back in lots of cases and trying to find other people that have done things like this, because there will have been cases where governance has supported stuff. It might not have been at your institution, but it will have been somewhere, because we know it's happening. So how on earth have people got approvals? and trying to get examples and saying, look, well, this person approved it, this governance procedure supported it, so why can't you? And sort of putting them on the spot a little bit and asking genuine questions of why not? What's the issue with this? What do you think is going to negatively impact someone as a result? So yeah, I think we need to do a lot more pushing and a lot less, I don't want to say whinging, but like assuming that governance procedures won't go through things. I think we just need to really push hard and say, look, this is what needs to happen. This is what our PPI group have said. This is a study that's done it before. And this is the way that we want to do it. Tell us how we can do it if this is not appropriate for you. And then see what.
And I do think we've just been doing things the same way. You know, trials take a long time to set up. You're often reluctant to cause any bother that might slow down your rec approval. But I do think researchers need to just do it more, and that will spread, you'd hope. But I think that there is an element of people just doing things the same way. We know what we need to do to get through the rec, and that's what we do. So
it's also about having patients and members of the public involved in those processes as well, and pushing for that to happen. So we know that usually there'll be a patient or a member of the public on ethics committees, but are they involved in the governance approval process? Maybe not. And maybe that's something that we need to push for as well, because we're not going to make change unless there's people on the inside helping us too.
We've got a question about how would this work in an emergency care setting alongside the deferred consent framework. So I think, yeah, so in terms of, I think this question means like, how would the INCLUDE framework work in an emergency care setting alongside the deferred consent framework? I think in terms of how it would be applied. Oh, Katie, do you want to answer this one? You're just about to.
No, I'm just adminning the questions.
Oh, right. I saw something pop up saying you'd like to answer it. Okay. So yeah, so I think it's something that's done, the INCLUDE Socioeconomic Disadvantage Framework is something that's done in advance. I'm not quite sure whether the question is about the more recent, the Impaired Capacity to Consent Framework, the INCLUDE one, or whether it's about the deferred consent, because there's a lot of guidance around deferred consent at the moment as well. So whether Heidi's sort of addressed that already in terms of the different frameworks and the work that's ongoing at the moment to look at how to combine that. I'm not sure if that's what the question was looking at. If it's not, if it's more about. Sorry, go ahead, Heidi.
I was just saying I would email Vicky. So Vicky Shepherd led the development of the Impaired Capacity to Consent framework, and she's much more up to date on the sort of legal frameworks and ethical frameworks that are part of that. And she does have an interest in, you know, all areas of inclusivity as well. So I think I would probably defer to her to answer that question.
She does one-to-one sessions as well, doesn't she? She's very willing to help researchers.
Yeah, she's fantastic.
Yeah,
and she's also one of the supervisors for Azar's PhD. So for the intersectionality idea that I said before, along with myself, Fran, and Sean. So there's no shortage of supervisors on that project, but Vicky is part of that as well to make sure that there will be representation from that group too. So
yeah, if it's the other sort of point in terms of looking at deferred consent generally in this framework, then I think you know, the idea is for it to be completed from the get-go in terms of like research planning. So hopefully that will be some things will be taken into account, and it can be tailored around those potential issues as well in advance. So there'll still be things, not all points I guess will be the same in terms of how you might approach them, but it'll help in terms of planning, I think, in completing this well in advance. Let's see where we're up to. I think we just had one or two questions left. The importance of PPI to ensure inclusive trials has been emphasised. How did you recruit a diverse group of public research partners for your work? What challenges were there? So I think it certainly is challenging trying to ensure that you can recruit a diverse group of patient partners. I think we created an advert and we put it on People in Research. We also, there's so the Northwest Applied Research Collaboration ARC as well sent an advert around there as well. So we tried to tailor it towards people's interest in this subject. people that had either been who would identify as being from a socioeconomically disadvantaged background, or I think we also put in receipt of government benefits and had an interest here. But I think it's a challenging one because of all those issues that we mentioned in terms of multidimensional, it being a multidimensional construct, it's being dynamic, all of those sorts of things really do make it really challenging in terms of recruiting. I'm not sure what the answer is to that, but that was how we approached it. And I think, we got some really useful responses in terms of, and contribution in terms of developing the framework and ideas really. But I do think that is an issue, isn't it, generally with research? So I think even making steps towards being mindful of that, which often isn't a thing at the moment in terms of public contributors or putting together assembling PPI groups. It's not even thought of in terms of like, oh, we need to make it diverse. It's just like we need PPI, because sometimes that in itself is tokenistic. So I think if we're thinking about it and being mindful about it and looking at the different ways and trying to think outside the box in some of those ways and identifying people in that sense, then that might be useful. But it's definitely a challenge that I think is being investigated as well at the moment in terms of how we can make PPI more diverse.
Yeah, I think from when you say it often ends up being we just need PPI, I think it ties into like being really clear in who you need to be involved in that PPI group and being upfront in your adverts about that. So if you've got an entirely white middle class team and you want other voices, you need to say that. So, and it might be that isn't the case and that you've got a team that is non-white and then maybe you want a white voice in there somewhere, but because of the research culture that we're in, that very likely isn't the case. But I think it is just saying we want a diverse group of voices and the team that we already have assembled offer this voice and we need somebody else, and allowing people to self-identify and come forward and say, actually, yeah, I fill that gap and I would like to be involved. I know I had conversations with people previously when someone had come forward and said, why are you asking for somebody from a ethnic minority group? That feels discriminatory to me. And I think people are going to take things in various different ways, and it's just trying to be as clear as you possibly can and as transparent as you possibly can about saying, we don't just want you for that reason. We want you because we want our team to have various experiences. So we don't have anyone from a socioeconomically disadvantaged background who is experiencing it right now. And we need that because what we're doing is trying to impact on these people, these groups in a positive way. So yeah, I think it is, rather than going to PPI ads and saying like, do you want to be involved in research? It's, we need this group. Do you want to be involved in research? And being more clear about it.
And just to add, I've been with some of our trials, because for trials you do want sort of patient specific or disease specific PPI, it can be quite difficult to get more diverse. So where we've struggled to do that, or there's been a sort of an existing PPI group, we've actually gone to more generic sort of primary care PPI group. We've got a deep end panel in Sheffield, and I think they do exist in other places, and they are happy to comment on our materials and everything else, even if they don't necessarily understand the disease area, and that has been really helpful. So you could get sort of non-disease specific input on sort of the language you're using, even if you can't find somebody to join your PPI group in particular.
I also think there's something there while we were talking about power dynamics earlier on. I've observed cases where a chief investigator has effectively been given the choice of two public contributors to include, and having no sort of real structure in terms of how they were selected. But to me, it was obvious that they selected them because they associated with them more. And the other person was from a socioeconomically disadvantaged background. And it was almost like that wasn't what he was looking for in terms of who he wanted to include. And, and it just completely defeats the object. So I think, again, the power dynamics thing comes in again. So it is worth considering that too, in terms of how those decisions are made. I think there's a lot of work that needs to be done there, sadly. But yeah, hopefully there'll be opportunities for change.
I agree with you, Fran. I think it's about training ourselves as well to make sure that we're we're actively looking to be challenged, rather than it just being like, we've got this PPI group and, you know, hopefully they'll agree with everything that we do. It's trying to make sure that we've got a group that feel empowered and happy and comfortable enough to challenge us and to change what we're doing, because otherwise what's the point? And that power dynamic thing is so important. I think trying to, when you have PPI groups, making sure that they've got maybe contact with each other, so that they're not just on their own, they don't feel alone, and that, you know, sort of safety in numbers kind of attitude, and giving them the environment to try and allow them to build connections within each other, so that they can then say, all right, I don't feel comfortable with this. Did you feel comfortable with this? No, you didn't. Okay, so there's two of us. That makes us feel a bit more confident to do that, and to trying to create that environment where we're open to being told off.
Definitely. And then there's one last question from Ratner. Are there any templates, resources that might be available to help make a case to finance departments that we could use to highlight the importance of making payments, cash payments, for public community involvement, engagement activities easier, simpler, and is a necessity in research? So I think that's something that's definitely lacking, and that came up throughout the meetings that we've had for the INCLUDE framework. It was often the question of like, well, what can we be doing? What are the strategies? There's lots of information that we have about barriers, but what can we actually be doing to make a change, and what kind of resources are available? And we weren't able to give a lot, you know, back in that sense, I don't think. So it feels as if the notes that we're taking from the public contributors meeting, that those are an amalgamation in terms of what we took from it in terms of strategies and potential resources. We're looking to create a paper that's sort of halfway produced at the moment, which will pick up on some of the slides that I was going through, and hopefully that can be used as almost like an interim resource, maybe, in terms of evidencing, because I don't think there's a lot out there at the moment. So it's something that I know there's interest in. So I'm sure there will be more in terms of resources we can draw from and evidence. But yeah, hopefully that will be a useful resource in the meantime. And the framework in itself, I think there are a few examples noted on the framework too, in terms of things that could be done.
Sorry, I was on mute. I think it is, again, just a case of constantly making that case. And if you have heard of someone that has made the case, then maybe asking them for the text that they've used and that kind of thing, and trying to all push at the same thing. And it's tricky, but I think if you, so some like a group like Egality, for example, obviously you have to cost them in, because they're making payments to the public and community involvement groups and that kind of thing, but they're also taking a cut for themselves because they're doing work. And I think it's almost a case of trying to flip the question around a little bit and saying, well, do you want us to not do it? Because if we don't do it, then these are the consequences. And making that really clear, rather than trying to defend why we're doing something, instead defend why we wouldn't, because what we've always done is not do things like this. And that's why we're in the situation where we have huge health inequalities between various groups. And all we're going to do if we keep doing the same thing is to push those further. So it is going to take longer, more money, more time, more effort. But this is how trials should have been done to begin with. And we just didn't know that as a community to begin with. So we're making changes to make it how it should have been. And trying to flip that question around, I think, is a really valuable thing, because you often get a response where it's just kind of people stuttering and going, okay, yeah, maybe you are right.
So yeah, that was the last question that we had. So thank you to all of you guys who have hung around for that additional half an hour. We all said beforehand that we'd be available sort of afterwards. So hopefully we've answered all those questions. But thank you very much for joining us. We hope the session's been useful, and please get in touch with us if you do have any other questions or anything else you'd like to know. The link there is on the bottom to the framework itself on the Trial Forge website as well. Thank you very much.
We'll do our best to get the recording of the webinar up on that link at some point over the next couple of days as well, so that you can come back and watch it. Thanks, everyone.
Thank you. Bye-bye.